We are live, madam.
So, Shilpi, shall I?
Yes, sir.
So, good evening and welcome the participants. Let me congratulate at the outset and also congratulate all the proud mentors who have today logged in for the today's All India Postgraduate Quiz, which is the third season and the second semi-finals. So, without much ado, let me request Dr. Shilpi to carry it forward. Please,
Okay.
Shilpi.
Yeah, thank you, sir. So, good evening, friends. I welcome all the quiz masters and all the mentors for today's episode, that is semi-final 2 of the season 3 of Big Q in association with Ophthalmological Society of Nagpur. So, this is our signature. And this is for Big Q.
आठ समंदर अपना अंबर
साला कुछ
खोज
जीतना
ले
ही
अब
नहीं।
तू अपने दम पर भूख मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर आठ समंदर अपना अंबर खोज ले अब तू अपने दम पर भूख मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर खोल दे पर खोल दे पर खोल दे पर खोल दे पर बंद घड़ी की भी रुकी हुई सुई होती सही दो दफा चुप क्यों है रहना मन का तू कहना रोके चाहे हिचकियां खोल दे पर खोल दे पर खोल दे पर
So, I welcome today's quiz masters. Our first quiz master is Dr. Sugato Paul sir. He is a consultant eye surgeon at Kolkata. Our second quiz master is Dr. Devakant Misra. He is a VR surgeon at Lucknow. And our third quiz master is Dr. Rohit Saxena. He is a professor at RP Center, AIMS, New Delhi. So I welcome you all for this semi-finals too. This is a video from our sponsors, that is the Microvision team, without whom it is unable for us to just conduct this quiz and carry forward years after years. So thank you, Microvision team, for the same. And last but not the least, I also thank Sai and the Numerotech team for the flawless conduction of the quiz after quiz at every episode. So with this, let me just introduce to the format of the quiz. So there are two semifinals and today's is the second semifinal. Total 22 teams played the semifinals, that is 11 teams per semifinal. And today, as you all know, is the second semifinal. Final will be after 2 weeks on Wednesday, that is 5th June at same time, 8 p.m. So for every team, you need to log in through two devices, that is Kahoot and Zoom. The first screen is the Zoom platform for live quizzing. 2 out of the 3 rounds today will be played face-to-face, and that will be only for the teams. While the second screen, that is the Kahoot screen, is only for the MCQ round, which is both for the audiences and the teams. So from today's semi-final, out of the 11 teams, 5 teams will qualify for the finals, and the criteria for qualifying for finals is the respective marks of the semi-finals only. No marks of the preliminary rounds or the quarterfinals will be considered. So now coming to the rules, format is first round is the MCQ round for both the teams and the audiences. Each set will have 5 questions. There will be no negative marking and you will get 10 seconds to answer the question. The second round will be the rapid fire round, which will be only for the teams. In that, you will need to answer 5 questions in 30 seconds time. So maximum 5 questions in 30 seconds. But yes, beware, there is negative marking. So you will get 10 marks for the correct response and -5 for the incorrect answer. If you don't know the answer, just say pass. And we request you not to waste your time on one question. So just say pass if you don't know the answer. Similarly, the third round is the case-based or the image-based round. In that, image will be shown to you, and depending upon the image, the 3 questions will be asked to you, and you will get 20 seconds for that. Similarly, there is negative marking in that round also. So teams which are not playing semifinals today or which have not qualified for the semifinals, you can play as an individual, as a private practitioner in the private practitioner category. So we request you to just name it as PP and not PG if you are playing on the Kahoot platform. So these are the audience prizes for today's episode. So with this, let us see the sample question of today to check whether the Kahoot platform is working properly or not. So according to the Supreme Court order, Rajasthan government is asked to close 68 mines that are less than dash kilometer from the Sarika Tiger Reserve. Your options are, is it 1 kilometer? Option B, 3 kilometers. Option C, 5 kilometers. And option D, 10 kilometers. And your time starts now. So the answer for this question is option A, that is 1 kilometer. So now I invite our first quiz master, Dr. Sugato Paul sir. He is consultant eye surgeon at Amulya Jyoti Eye Foundation, Kolkata. He is a former trust consultant and director at Diabetic Retinopathy Screening in UK. He's a joint secretary of OSWB and a managing committee member of IZOC. I welcome you, sir.
Thank you, Dr. Shilpi, and thank you, Prashant, Dr. Prashant, for giving me this opportunity to participate consecutive years, and thank you so much. I hope the PGs will enjoy this quiz as usual. Thank you. So, shall we go on to So, this is the MCQ round, which everyone will be playing, I hope, through Kahoot. Just listen to the question carefully and answer. They are quite easy. So we'll go to question 1. In Azure, that is acute zonular occult outer retinopathy, which statement is correct? So you have to pick the correct statement. Option A is photopsia is a recognized feature. Option B, visual acuity, visual loss is caused by retinal necrosis. Option C, fluorescent angiogram is useful for the diagnosis. And option D is oral prednisolone is the treatment of choice. Your time starts now. Okay, and the correct answer is option A, that photopsia is a recognized feature of this condition. So it's a busy slide, so just wanted to let you know that Azure was described by Dr. Donald Gus in 1992, and the acute vision loss is associated with photopsia and occurs mostly in females. I'll not go in details, but fluorescent, FAF, OCT are the common things which are used in electroretinogram, but fluorescent angiogram is not very helpful in this condition. And also, ERZ is always negative, always abnormal in Azure, and proven treatment we don't have so far consensus. Systemic corticosteroid has been tried, immunosuppressive have been tried, antiviral have been tried, but no consensus yet. So we'll move on to the next question. Regarding retinopathy caused by shaken baby syndrome, which is true? So one of the choices are true, and you have to answer that. The patient is usually between the age of 3 to 5 years. Number 2, or option B, retinopathy may resemble the central vein occlusion. Option C is the visual prognosis is generally good, and option D is skull fracture is always present. So you have to choose the correct answer, and your time starts now. Okay, it was quite easy, and the correct answer is option B, that retinopathy may resemble central retinal vein occlusion. Usually, the patients are of below the age of 2 years, and majority are about 8 months to 12 months of their age. Skull fracture results only when the baby is thrown against the hard or soft surfaces and shaken. Visual loss is often seen in the surviving babies, so prognosis is pretty bad, and retinal hemorrhages ranging from few scattered hemorrhage to extensive hemorrhage involving multiple layers of the retina resembling CRVO is often seen. So with this, we'll go to question number 3 of this round. So best vitelliform macular dystrophy is transmitted as option A, autosomal recessive, option B, autosomal dominant, option C, X-linked, and option D, none of the above. Is very easy question to answer. Your time starts now. I'm sure everyone got this right. And the answer is option B, that is autosomal dominant. So best vitelliform macular dystrophy is basically an autosomal dominant disorder which classically presents in the childhood with the striking appearance of yellow or orange yolk-like lesion in the macula. So we go to the question number 4 of this round. And again, an easy question, so everyone should get it. Hypopian corneal ulcer result in the following complications, except, so you have to pick the wrong one, except option A is perforation, option B is panophthalmitis, option C is secondary glaucoma, and option D is corneal anesthesia. So which is not a complication of corneal ulcer, hypopian corneal ulcer? Time starts now. And again, it's very easy. And answer is option D, that is corneal anesthesia. Hypopian corneal ulcer causes all these complications except corneal anesthesia. So we go to the next question. Which of these is true regarding the difference between ARN, that is acute retinal necrosis, and PORN, that is progressive outer retinal necrosis? The difference which is true, option A is ARN is associated with herpes simplex virus but not PORN. Option B, ARN has a worse visual prognosis than PORN. Option C, ARN is associated with AIDS but not PORN. Option D, retinal detachment is more common in ARN than in PORN. Your time starts now. So time's up, and the option answer is option D, that is retinal detachment is more common in ARN than in PORN. So if you move on to the next slide, both ARN and PON have viral etiology, including HSV. Usually, ARN occurs in immunocompetent patient or in patient with HIV as well, but with minimal immune dysfunction, whereas PON occurs in patient with HIV with significant immune compromise. Visual prognosis is worse in PON, which affect the posterior pole. So we'll end this section, and now we welcome Dr. Divyakan Mishra. Dr. Shilpi will be introducing Dr. Mishra. Or
Sir,
shall I introduce?
Yes, sir, you introduce.
Okay, Dr. Divyakan Mishra is done his VR training from Sankaradeva Netralaya, Guwahati, and from Byers Eye Institute, Stanford in San Francisco. He is Vice President of Young Ophthalmology Society of India. He has received several awards, including Achievement Awards by Asia Pacific Academy of Ophthalmology, Ophthalmic Hero Awards of India, 3 consecutive years from 2018, Yasu Tano Award, which is the Asia Pacific Academy of Ophthalmology Award in Singapore 2017, and others as well, like IGO Awards. He has several publications, and he is an invited faculty in AO, APAO, and URetina. Several presentations, we all know him very well. He basically doesn't need introduction, and he's a lovely person to be with. And welcome, Dr. Mishra.
Thank you so much, sir. Thank you so much.
So,
Yeah,
Dr.
Doctor,
Divyakan,
can
we
we go
will be
ahead?
starting with the teams.
Yeah,
Okay.
please.
So, we will first introduce them. Then they will select the set which they want to play.
Okay.
Okay.
Perfect.
And then we
Perfect.
will, yes. So we'll, with the introduction, we know them, and also we can check their audio and video also. So team 1.
Hello, can you hear us?
Yes, we can hear
Yes.
you, but we can't see you
Properly. Yeah.
enough.
Tilt your camera towards you.
We can see half of you. Yeah, perfect.
Yes. So
Okay,
please introduce yourself.
Hi, sir. Hi, ma'am. I'm Dr. Mautika. He is Dr. Mahesh, and we are from Sarojini Devi Eye Hospital, Hyderabad, and our mentor is Dr. L. Pratima, ma'am, from glaucoma department.
Okay. Hi, Doctor. So let's start.
Yes, yes.
So which set you want?
Set 2.
Set 2. Actually, I wanted to hear the voice of your partner.
Set 2.
Yeah. Okay, great. So, Dr. Devakan?
Sure. Let us play the slide.
Yeah.
So it's a very easy one. A school-age child is referred for evaluation of an abnormal pupil as shown. Just have a look at the diagram and then we'll go ahead with the questions. Dr. Shilpi, can we have the questions now?
Yes.
So can you diagnose this?
Persistent pupillary membrane.
Okay. What is the pathophysiology of this?
The absorption of the next question.
Okay. And how do you manage this?
Pupilloplasty.
Come again?
Pupilloplasty, the removal of the membrane.
Okay. So,
The absorption of the membrane.
yeah. So you
Incomplete
okay. So you got the diagnosis correct. Pathophysiology is that it results from incomplete involution of the tunica
Tunica.
vasculosa lentis. Now, management. Let's decide whether we'll give it that to or not. So most of the cases can be managed without anything because most of the times we see that even such severe cases don't have a visual impairment. And patients, since they are of young age, we should be monitoring them for amblyopia. And at times we need surgery, as you said, right? So maybe we can give that to you. Dr. Shilpi, what do you say?
So it's your, it's your decision.
Let's give that to
Okay.
yeah, let's
Yes.
give-
So
yeah.
they, 2 correct and 1 pass. So it is plus 20.
Perfect.
Thank you.
Perfect.
Okay. So team 2.
Hello, ma'am. Can you hear us?
Yes.
Ma'am, this is Dr. Astha and
This is Dr. Arun, ma'am. We are from Jipmar, Pondicherry. Our mentor is Dr. Nirupama Kasturi.
Okay. So which set you want?
set 7, ma'am. Set 5. Set 5.
Okay.
Perfect. So, Dr. Shilpi, let's have the questions, the
Yes.
slide now. Yeah. So, a 30-year-old man presents to the department with a 10-day history of accelerated discomfort and redness in both the eyes. We are just showing photograph of one eye. The patient exhibits sign of pain, and the examination reveals this sharply demarcated peripheral corneal ulceration with a central overhanging edge, which is seen here in each eye. So, can we have the questions, Dr. Shilpi?
Peripheral ulcerative keratitis.
Okay.
Or
How do you manage this?
with steroids, sir. Topical steroids.
Okay. And can you give us more differential diagnosis? At least-
Murans ulcer and marginal keratitis.
So let's have the answers. Okay, so this happens to be a case of Moran's ulcer,
Okay.
and then management, of course, depends on that. We do either steroids, and at times some cases need limbal conjunctival excision or lamellar keratoplasty as well. So these are basically a differential diagnosis of peripheral degenerations like TMD and PMD, right? So I think the diagnosis is wrong. So what was your answer?
Old Moran.
So I
You
said
said Moran's? Okay.
Yes.
Okay.
Initially, actually, they said
PUK
this.
and then
Then
Murans.
They said then Murans also.
Okay. Okay. So let's
So
give
what
that
about
to
the
them.
third? What about the third?
Third. Yeah. So what was your response for the third?
So I said marginal keratitis. I said actually the differentials for PUK.
Okay. So that we would want something more specific for that. Okay. So we'll give that first and second, we'll give that to you.
And
Okay.
what about okay?
Yeah.
So no
First
marks.
and
Neither the negative marking for the third.
Uh, okay, let's not give them negative marking,
Okay,
but we would,
sure.
yeah,
Okay. So plus 20 to them also.
done.
Team 3.
Good evening, ma'am. I'm Dr. Sharmila and my teammate is Dr. Q. We are from AIMS Raipur and our mentor is Dr. Somen Mishra, sir.
Welcome. Which you want?
Set 3, ma'am.
Say 3.
Okay, so let's have the history. So 32-year-old man has painless mass, which is seen here in the photograph, located in the superior lateral aspect of left upper eyelid. It has been present for the past 4 months. There's no history of any trauma or any surgery of the eye or any chronic conjunctivitis. Now the ocular examination are normal apart from this mobile translucent mass, which is more visible on the eversion of the upper eyelid. So let's have the questions, Dr. Shilpi, please. Please diagnose them.
Pass.
Okay.
Lacrimal gland.
Okay. And how do you manage this?
Excision.
or derupil.
Diagnosis is the lacrimal sac cyst.
Okay.
All correct or
Okay, we'll give it to them, right? Dr. Shilpi, what do you say?
yes, okay. Okay.
Thank you,
But
sir.
because
Thank you,
next
thank you.
questions didn't reveal basically the diagnosis, so we can give.
Thank you, sir. Thank you.
Okay.
Okay, congratulations. So all 3 correct, 30 marks worth. So team 4.
Good evening. Good evening, ma'am.
Yeah,
Good
please
evening.
introduce yourselves. Yeah.
Are we audible?
Yeah, you're audible and visible. Please go ahead.
My name is Dr. Reshna ma'am, sir, and my teammate is Dr. Roja, and our mentor is Dr. Devius Ratnakumari.
Great.
So which set you want?
Set one.
What?
Set one.
One. Okay. Okay.
Okay, so this is a case of a 30-year-old male with no significant history, presented with sudden vision loss after sneezing. His visual acuity is 660 and slit lamp was normal. Let's have the first question. You just have to see the photograph and answer. What is the diagnosis and the cause for it?
Pass.
Okay, pathophysiology.
Board-shaped hemorrhage, subretinal hemorrhage.
What causes?
Next, pass.
How do you manage it quickly?
Vitrectomy, hemorrhage aspiration.
Okay. So this is a case of this is a subhyaloid hemorrhage, which is secondary to something known as Valsalva retinopathy. And how it happens is this is a pre-retinal hemorrhage, as you said, which is boat-shaped, caused by a sudden increase in the intrathoracic or intra-abdominal pressure against a closed glottis, which leads to rupture of small capillaries, and then there's extravasation of blood between the ILM or the vitreous or subhyaloid space. Now, management, at times we see that these cases spontaneously resolve. We usually wait for some time. Otherwise, we can go for a YAG hyalodotomy, or if it's too late and the blood is not resolving, we can also go for vitrectomy. And so I think all the answers were wrong. Okay, we will, yeah.
Basically, they passed.
Vitrectomy, I said. Vitrectomy, I said, sir.
Yeah, you said, but I think yeah, because you said blood aspiration and vitrectomy, so these was not the correct terms, and since the diagnosis was wrong, so I think.
Okay.
And vitrectomy is usually not the first line of management. We rarely do vitrectomy. Usually this resolve on its own or by a YAG hyalodotomy, right? Okay.
So team 5.
Good evening, everyone. Myself, Archana Singh. I'm Dr. Priyanka from AIMS Raipur, and mentor is Dr. Madhuri. Ma'am, set 8.
Set 8.
So let's have. So a 30-year-old patient presents with sudden diminution of vision in right eye for 3 days. Complains of black stationary spot in the middle of the vision. He has 612 vision, and he has been under treatment
Yes,
for nasal polyp using a nasal spray. Right? Can we have the questions? Please diagnose.
Yes,
Yeah.
CSCR.
Okay. And name this.
Mushroom.
Okay. How do you manage?
Management is eplerenone, nepafenac, eplerenone or observation.
Specific to this case.
Ink blot sign. No.
Specific to this case, how do you manage it?
वो करते हैं ना laser.
The time is.
No, sir. We will give for CSCR. We will give this eplerenone therapy specific to this case.
So the you got first 2 right. So the nasal spray for the nasal polyp usually contains steroid. So if we stop the steroid, we don't need to do anything, and it will resolve on its own, right? So eplerenone is debatable, and nepafenac and all these things usually don't work in these cases. Okay. So 2 of them are right and 1 is wrong.
So plus 15 to them.
Okay.
Okay. Team 6.
Please unmute yourself.
Good evening, everyone. I am Dr. Anubhav Singh from Rio Sitapur Eye Hospital.
Good evening, everyone. I am Dr. Meghna Dixit from Sitapur Eye Hospital, and our mentor is Dr. Indraneet Saha, sir.
Great. So ready?
Just put your camera in the center so that we can see both of you, and if
Okay, now,
possible, yeah, can you remove the background?
Sir, I don't know actually how.
Sir, it's already been said.
Okay, let's go ahead.
Yes, sir.
So which set you want?
Ma'am, 10, set number 10.
Okay.
Okay, so a 22-year-old healthy woman describes several years of progressive worsening in her vision. She does not have any additional complaints. She passed routine vision screens throughout childhood. She denies any laser exposure, sun gazing, and recreational drug use. Her vision is 20/17 this side. Fundus examination shows subtle foveal granularity, and this is the OCT picture right here. Can we have the questions? Can you describe the OCT finding?
The outer retinal layers, there is disparity.
Okay, next.
Most likely
The most likely
so mostly it
underlying
can be solar retinopathy, sir. Solar retinopathy. Sun exposure. Differential diagnosis.
time is up, but you can attempt.
Pass. That DD is pass.
Okay. So this is shows the absence of the ellipsoid zone, and this is known as an optical gap, right? And this happens usually due to abnormal processing of the visual cycle byproducts. Differential diagnosis could be achromatopsia, Stargardt's macular telangiectasias, right? So maybe we can give you the first one, but we would have preferred something more specific. But let's give them the first one, and
Second is wrong. Third, they have passed.
third they have passed. Yeah.
So +5 to them.
Yep.
Thank you.
Thank you.
Okay, welcome. Team 7.
Good evening, ma'am. Are we
Good
visible?
evening, ma'am.
Good evening.
I'm Dr. Pujita.
I'm Dr. Pratik. We're from JSS Medical College, and our mentor is Dr. Soumya HV.
Ma'am, we'll take set 4.
Set 4.
Oh.
So,
Okay, so this is the case. A 38-year-old man accidentally struck in the right eye with a bungee cord 1 day prior to this examination. The patient is complaining of double vision, especially when looking down, but has not noticed a change in the visual acuity. There's a small laceration on the inferior conjunctiva. Post-duction test, FDT demonstrates slight restriction to elevation and depression. Ocular motility is shown in the image. There is 1 mm of proptosis of the right eye. CT scan of the orbit reveals soft to swelling. Okay. Some part of the question is missing, I think. But I think this much is good enough for diagnosis. Yeah.
shall I start the questions?
Yeah, please.
Okay.
Can you describe the motility disturbance? Your voice is not very clear.
Lost direct depression.
Okay. The diagnosis.
Lost passive.
I think your voice is not very clear. Dr. Shilpi, can you clearly hear what they are saying?
No, I can't hear.
Blowout fracture with inferior rectus entrapment.
Okay.
Management will be orbitotomy with
Floor fracture repair.
orbital floor repair with titanium implant.
Okay. And what about the first?
What did you answer for the first?
Direct depression is restricted. Inferior rectus is limited.
Okay.
Okay. So I think first was right. Right. And diagnosis is laceration of the inferior rectus muscle, and then you explore the muscle with repair and reattachment. Okay.
So what do you suggest?
You can give them the first one.
Okay.
Can we have another question for them? Because I think there was the question
Okay.
not complete. Do we have that option?
I don't think.
Because some part of the question was missing.
Okay.
Let's get back to them, think about it, and get back to them. We'll see that if that the after the but where there was a clincher in the diagnosis or not.
Okay.
and take a call afterwards, right?
Sure. Okay.
We'll get back to you, okay?
Okay.
Thank you.
Team 8.
Good afternoon, sir. I'm Dr. Pratik from Shankarai Hospital.
I'm Dr. Pooja from Sankarai Hospital and our mentor is Dr. Vivek Chaitanya, sir.
So which set you want?
6.
Okay, so a 4-year-old boy presents with decreased vision in his right eye. His mother reports that his father and grandfather have had vision problems. Slit lamp is normal, and this abnormality on fundus is shown. Okay, right eye is just shown. Can we have the question? What is the diagnosis?
Best vision.
Okay, and what is the inheritance pattern in these cases usually?
Autosomal dominant, sir.
Okay, and which diagnostic test is likely to be abnormal?
Electroocular.
Time is up.
So the answer all correct.
All correct. Okay, all are correct. Congratulations.
Thank you, sir.
Team 9.
Good evening, ma'am.
Good evening.
Ma'am, are we visible and audible?
Yes.
Ma'am, I'm Dr. Ashwati and my teammate is Dr. Aparna. We are from Kottayam Medical College and our mentor is Dr. Padmasree, ma'am.
Okay. Okay. So which set you want?
7.
7.
Okay. So a 22-year-old woman presents with poor visual functioning in low light conditions and retinal abnormality as shown in the image. She wears hearing aids for moderately reduced auditory acuity. She has no family history of the disease. Okay, we'll move ahead to the questions. What is your diagnosis?
Retinative pigmentosa.
Okay, and what is the common gene mutation in these conditions? Which is the gene that is involved, specific to the history that has been mentioned? Okay, and inheritance pattern?
Autosomal recessive or X-linked or
Okay. So we had something extra in the history, right? So this woman has a syndromic retinitis pigmentosa, and it is inherited retinal dystrophy. So his findings have hearing loss also, and it is most likely a diagnosis of Usher syndrome type 2, which has a genetic mutation which is USH2A with an inheritance pattern of autosomal recessive. So your answer would have been the diagnosis, complete diagnosis we would have preferred, which is Usher syndrome type 2, right?
So half marks to them, Dr. Devagan?
If we can give half for the first,
Yes.
that is
Okay.
possible.
Great. So plus 15 to them.
Yeah. Okay.
So now the second last team, that is team 10.
Good evening, ma'am. I'm Dr. Gaurav Pandey.
And my name is Dr. Sangana. Our mentor is Dr. Deepak Mishra.
Can you be a little closer to the mic, please?
Are we audible now, ma'am?
Yeah.
Better.
Thank you.
Which it?
9. 9 you said, right?
Yes.
Yeah. Okay. Let's go ahead.
Please be louder because now we can't hear you.
Okay. Okay.
Yeah.
So this is the question. A 23-year-old graduate student says he has a white spot on her eye that she wants to be removed. Can we have the questions, Dr. Shilpi, please? So please diagnose
So it is a limbal dermoid.
Okay. And any associated syndrome you know of?
Goldenow syndrome.
Okay. And how do you manage these cases?
So we can do a tectonic graft or excision of limbal dermoid with tectonic graft.
Okay. Can we have the answers? So almost, I think we'll give them all, right?
All correct. Yes, yes. Okay.
Thank you, ma'am. Thank you, sir.
Welcome. So the last team, team 11.
Are you
Good
guys
evening,
there?
ma'am. Good evening, ma'am. Can you
You are not audible.
Hello, ma'am. Can you hear us?
Yeah.
Good evening. I'm Dr. Sumaya, final year PG from Aravind Eye Hospital, Coimbatore. I'm Dr. Flawny. Our mentor is Dr. Abhishek.
Okay.
Can you be little more louder and near to the screen, please?
Okay, ma'am. Okay,
So you have no option left except for the set 11. Okay.
Yes, ma'am.
Sure.
Okay, so a 4-year-old child is referred for a new onset of bilateral epiphora. Examination shows these lashes on both lower eyelids, which are rubbing against the inferior cornea. Okay. Can we have the questions, Dr. Shilpi? What is the diagnosis?
Trichiasis. Consider lentopia.
Okay. So, define or describe the condition. What are the symptoms of condition?
Inward turning of margin led to.
But why it occurs?
Because of congenital lentopia.
What is the management?
Okay, let's have.
Yeah.
So this is a condition that is known as an epiblephron. So which is a condition in which the eyelids, pretarsal muscle and skin ride above the eyelid margin to form a horizontal fold of tissue that causes cilia to assume a vertical position. So it appears like a trichiatic lash. So this may resolve spontaneously in the first few years of life as a result of differential growth of the eyelids and the facial bones. Surgery to remove a small strip of skin and orbicularis from the subciliary eyelid may be necessary in some of the cases, right? So I think we will not give any to you in this condition. Okay.
And
We wanted a
first
very
is
specific
wrong.
answer.
Yeah.
Yeah.
So with this, we end with the image or the case-based round. So now we move on to the MCQ round 2. So I again invite Dr. Sugatopal sir for the same.
Yeah. Can we have the first question, please?
Yes.
So, which of the chemical is not used for tattooing of the corneal opacity? Option A is gold chloride. Option B is silver chloride. Option C is platinum chloride. And option D is hydrogen hydrate. So the answer is option B, that is silver chloride. It's not used for the tattooing of the corneal opacity. We move on to the next question. So fascicular ulcer is present in option A, Murren's ulcer. Option B is neuroparalytic keratitis. Option C is herpes zoster. And option D is marginal ulcer. So where it is present? Time starts now. So fascicular ulcer is present in Murren's ulcer. So we move on to the next question. Again, an easy one. Which of the following findings, retinal findings, are associated with rhegmatogenous retinal detachment? Option A is paving stone degeneration. Option B is cystic retinal tuft. Option C is pars plana cysts. and option D is congenital hypertrophic retinal pigment retinal epithelium. So which of them is associated with RD? Time starts now, please. So again, an easy question, and the answer is option B, that is cystic retinal tuft. They are associated with rhegmatogenous RD. So we move on to the next question. So again, an easy one. The features of macroaneurysms are all except. So which one is not a feature? Option A, retinal artery occlusion. Option B, more common in temporal arcade than in nasal arcade. Option C is progressive enlargement, and therefore early treatment with laser photocoagulation is recommended. And option B, it occurs in Irvine syndrome. So the time starts now. So the answer, which of the features is, all of them are associated macroaneurysm features except option C, that early treatment is not required. Quite often they resolve. So this is the correct answer, as it was except we asked for. And the last question of this round is band-shaped keratopathy is due to option A, calcareous degeneration. Option B is hyaline degeneration. Option C is fatty degeneration. And option D is elastosic degeneration. Time starts now. So band-shaped keratopathy is due to hyaline degeneration in the cornea. So with that, we come to the end of this round. Over to Shilpi, Dr. Shilpi, please.
Thank you, sir. So this is a time for commercial break. So now it's time to declare the winners in the private practitioner category of the last episode, that is semi-final one. So these are the winners in the private practitioner category in the last episode. So we request all of you to please log in at the end of the quiz so that we can have a small chat with you. So our next quiz master is Dr. Rohit Saxena, sir. He is a faculty at RP Center, AIMS, Delhi, but because of some emergency, he is unable to join us today. So I request our other two quiz masters, Dr. Sugatopal sir and Dr. Devakant Misra, to please take over his questions so that we can proceed with them. So Sugato sir, we'll start with you.
Okay.
Okay, sir. So this is the rapid fire round. Again, I'll just say the rules that you will be given 30 seconds and you need to answer 5 questions in the 30 seconds. So here there is again the negative marks are there. If you don't know the answer, just say pass. So now this time we will start randomly with the teams, and the first team to play will be team 8.
So yeah, so you have to choose your set of questions.
Yes, sir. Yes, sir. Teammate, are you there?
Yes, ma'am, we are there.
Okay. So we are going to the rapid fire segment now. Okay. So teammate, please select your question. Set.
Set.
3.
We can't hear you, beta.
Set 3, ma'am.
Set 3. So please be loud. Okay.
Yeah.
Yeah.
So can we have the question, please?
Yes, sir. Yes, sir.
So most sensitive test for diagnosing myasthenia gravis is
multiple nerve stimulation test.
field of view of ultra-wide field retinal imaging. Mizo Nakamura phenomena is seen in where?
Oguchi disease.
Firefly study was done to check efficacy of aflibercept in which disease? The principle of TNO test is?
Anaglyphic principle.
Okay, so we'll give that because we started the question before the time.
Yes, sir.
So, yeah.
So
So
plus
the-
30. Yes, sir.
Yeah. So now, what did you answer for the first one?
So they yes, repeated nerve stimulation. That was
right.
Yes, sir.
Ultra wide field, you said pass. The question 3 also you didn't answer.
So
No,
they
sir, we answered.
The answer, it was
Okay.
right, sir. It was Okuchi.
200, okay, I couldn't hear. Oguchi disease, you didn't answer.
Sir, the answer.
Okay, how did I miss hearing them? Okay. So, 3,
Pass.
4th and 5th was right.
Fifth
So,
was right. So 3 correct and 2 pass.
No, they answer first one right, last one right, Oguchi is right, and
2 were
ultra
pass.
wide field, was it pass, isn't it?
Yes, sir.
Yeah.
So 3 correct and 2 pass.
Yeah. So 30 marks. Thank you.
Yes, sir.
Thank you, sir.
So is Dr. Divyakan going next or?
No, sir. You will do the first 6
Okay.
and then Divakan, sir.
Okay. So which
So
team
now-
is on?
So you tell.
So we'll go with team 5 then.
Okay. Team 5.
Is Dr. Archana and Dr. Priyanka, mentored by Dr. Madhuri. Yeah.
Yes.
So which set do you want to?
6.
Set 6.
Yes, ma'am.
Okay.
So, yeah, first question, please. DRS is associated with which genetic mutation?
Pass. Pass. Second question, pass.
Test used for measuring the amount
Occipital lobe, third. Fourth.
Fourth.
Pass.
Okay. And the last one?
and number of is most common
Best,
inherited
Stargardt's.
macular dystrophy.
Okay.
Stargardt's.
Okay.
So DRS you passed. Question 2 you passed. What did you answer for question 3?
The third they answered and fifth they answered. Hello?
Yes, ma'am. Third and fifth. Third and fifth we answered.
Third and fifth. So the answer to the first question is CHN 1. Answer 2, yes, it is prism bar undercover test. Third is left occipital lobe lesion is there if you see the right-sided homonymous hemianopia. The other name of curly fiber corneal dystrophy is Thiels-Benkes dystrophy. And the most commonly inherited macular dystrophy is Stargardt's disease. So 2 correct and 3 pass. So 20 marks to them. Sugata sir? Dr. Devakant?
Yes.
Can you please? I think we have lost his connection.
Sure.
So,
Let's go ahead. Yeah.
so which team you want them to play?
Okay, let's have team 7.
Okay. Team
Yeah.
7.
Dr. Paul is here, I think.
Yeah, I'm back. I got disconnected somehow. So,
Yes.
yeah.
So we have selected team 7 on your behalf, sir. Yeah.
Yeah. So can we have the question?
Team 7.
Ma'am, set 8.
Set
Which
8.
set do you want?
Please
8.
be louder, please. है ना?
Okay, ma'am.
We'll mark that.
Yeah. Team 7. Okay. So your time starts now.
Foster classification system is used for which
Pass.
ophthalmic? Sorry. Legionnaires conjunctivitis is associated with
What? What you said?
Pass.
Pass.
extraocular muscle with the longest arc of contact is
Superior rectus.
diffuse is which order of aberration?
What?
Perical.
Okay, last.
Okay,
Weak
last
syndrome.
question.
Okay.
So the answers are not very clearly audible.
Yes, sir. So first they said pass. The answer to this is oculocicatricial pemphigoid. Second, they also passed. Third, they said superior rectus. That is the wrong answer.
Wrong.
Fourth,
Defocus.
we wanted the order of the which order. So they said, I think
Spherical.
I think that is also wrong. The
Wrong.
last is correct.
So they got
So 0.
one right,
1 correct, 2 wrong, 2 pass.
2
So
wrong.
it comes
2
to
pass.
0.
0. Yeah.
So now which team, sir?
We'll go with team 3, if that's okay.
Yes, sir. Yes. Team
Yeah.
3.
Yes, ma'am.
Yes, ma'am.
So which set you want?
Set 5.
Okay. You
Okay.
want set 5.
5.
So let's start.
Okay.
Yes,
Start
ma'am.
now. Best of luck. Yeah. So 4 prism base out test is used for the diagnosis of which
Microtopia. Microtopia.
chloroquine toxicity can be detected earliest by which test?
Pass.
Pass.
Most common indication of surgical intervention in congenital ptosis.
Amblyopia.
What is the size of 27G vitrectomy system?
0.4 millimeter.
Triggerfish device is
Pass.
used for which purpose?
Okay.
So,
3 correct, 2 pass.
amblyopia 0.4 and microptears, right?
Yes.
So
the chloroquine
30 marks.
toxicity is detected earliest by multifocal ERGs, and the triggerfish device is used for IOP monitoring. That is 24 hours IOP monitoring. Okay, so plus 30 to you.
So well done. So we have now done with 1, 2, 3, 4 teams. We'll go to team 11 now.
Team 11.
Yes, sir.
Beta, please be loud.
Yes, sir.
So which
Which
set
set
do you
you-
want?
So set 7.
Please
Set
come
7.
closer to the mic. If we can't,
ma'am.
we are unable to give you the marks.
Yes, ma'am.
And you can answer even before I complete the question if you can see them on your
Yes.
screen,
Yes.
because 30 seconds is there. Okay.
Okay, sir.
Yeah. So Iberdomon is used in the treatment of
Leber's hereditary optic neuropathy.
bilateral SO policy. Will have what kind of head posture?
Pass.
Most common indication for using keratoprosthesis is
Oculocitated pemphigoid, Steven Johnson syndrome.
as per OCT based classification, VMT syndrome. What is the width of the
More than
attachment?
400 micrometer.
We'll keep the next question to them because it's long one. Angle subtended by 660 letter of Snell chart at 6 meter is
5 minutes.
Okay.
okay. Can we have the
Yes, sir. So first they correct right, that is LHON. Second, they
Yeah.
pass. The answer to that is chin down position. Third, they also gave the correct answer, that is Steven Johnson syndrome. Fourth, they answered wrong. They said more than 400. Actually, it is more than 1500 micron. Yeah, and the fifth, it was correct answer. So plus 25 to them.
Yeah. So well done. So over to Dr. Mishra now.
Okay, sir. No issues.
Yeah.
Okay, so let's have team first. First, team one.
Team 1. Okay.
Can you see us, ma'am? Can you hear us?
Yes.
Set 2. Set 2.
Which set you want?
Set 2.
Set 2.
Okay, let's have the questions.
Yeah. Please.
So Argus retinal prosthesis is inserted at which retinal plane?
Pass.
Child presents with triad of nystagmus, head bobbing, and torticollis. Likely diagnosis.
Pass.
Okay. Beaten bronze appearance on cornea.
Pass.
Okay. Most common orbital structure to be involved in IgG4 related ophthalmic disease is GDX nerve fiber analysis is based on which principle?
Only 2 seconds more. Okay.
So it is done at the epiretinal plane. The diagnosis for the second was Newton's. Eaton Brown's appearances in eye syndrome. Most common in IgG4 is lacrimal gland, and GDX nerve fiber. The principle is scanning laser polarimetry. Let's
So
go
they
to the
passed?
next team.
Yeah, all the questions.
All pass.
So next team.
Let's have team 6.
Team 6. Sitapur Eye Hospital.
Yes, good evening.
Great.
Yes.
Let's go to the set.
Yeah. Which set you want?
Set 10.
Set 10.
Okay, let's have the questions, Dr.
Yes.
Shilpa.
8 minutes. Just a minute, please.
Yeah.
Team 6. Okay. Yeah. Because I have to mark simultaneously.
So NPCB 6 defines visual impairment as
Pass.
a young female with ptosis and history of episodes of upper lid swelling with cigarette paper appearance of upper lid skin. Diagnosis.
Pass.
A drug of choice for capillary hemangiomas.
Propranolol.
Okay. Crowding phenomena is seen in
Amblyopia.
and culture media used for culturing acanthamoeba. I think the time is up.
Yeah.
Yeah.
We'll give you 2 seconds more if you answer. Okay.
Okay, so vision less than 6. Okay, so less than 618. The diagnosis for the second was blepharitis and caliasis. Drug of choice, you got that right. Amblyopia, you got it right. And the fifth one is non-nutrient agar with E. coli. 2 correct? Yeah.
Yes, 2 correct and all pass. So it is plus 20.
Done. Let's have the second team, team 2.
Hello, sir. Can you hear us?
Yeah, we can
Be
hear you.
closer to the mic.
Yes, ma'am.
Closer.
Which set you want?
Set 4, ma'am.
Okay. So you want.
Okay, are you guys ready?
Yes, sir.
Yeah, let's have the questions. So the first one is go-to procedure is used for
Pass.
HLA association of weak-age disease.
Pass, sir.
Okay, World Sight Day celebrated on
Pass, sir.
mitomycin C is derived from which organism?
Pass.
Drug of choice for sino-orbital mucormycosis.
Amphotericin B, sir. Liposomal amphotericin B.
Streptomycin C is affordable.
Okay. We'll give you that also.
Okay.
Okay.
The first is head posture in nystagmus. VKH is HLA-DR4. World Sight Day is celebrated every October 10th. And streptomyces and amphotericin B. So we'll give them 4th and 5th.
Yes, sir. Yes.
Yeah. Rest all pass.
So plus 20. to
Thank
the
you.
team. Yeah.
Okay.
So now
Team 10.
team 10.
Yeah. Okay, are you guys ready?
Sir, are we audible?
Yes,
Yes.
we can hear
Yes.
you.
Which set you want?
Set 9.
Set
Set 9.
9.
9.
Okay.
Be closer to the mic.
Yes.
Let's set 9.
Team 10, set 9. Okay.
Are you guys ready?
Yes, sir.
Yeah. So which extraocular muscle is supplied by only one?
Lateral FS.
Okay. Which lethal tumor is associated with aniridia and needs to be screened for?
Retinoblastoma.
Okay. What is the principle of OCT?
Laser interferometry.
Hydroxyamphetamine test is used for diagnosis
Candle
of...
syndrome.
Come again?
Candle syndrome. Candle.
Candle wax dripping on fundus is seen in which disease?
Sarcoidosis.
Great.
Okay.
So one is wrong.
Yeah. Yeah. Second, you got it wrong. The rest, I think, is right.
Yes, rest is
Thank you, sir.
the Wilms tumor, है ना? Aniridia.
Yeah.
Sorry, ma'am.
No,
It's
sorry.
okay.
Don't be sorry. Yeah. You are allowed one wrong answer. Yeah.
Exactly. हमने तो इतने भी नहीं दिए रहते थे.
So let's have team 9.
Team 9.
Hi, sir.
Yeah.
So which set you want?
Set 1, ma'am.
Set 1.
Okay.
Okay.
Are you guys ready? Let's have
Yes,
the
sir.
question. The logMAR value change of every optotype in ETDRS chart is? Okay.
Be louder.
Patent lines are seen in which condition?
Papilledema.
Okay. Planet trial for which drug?
Yes, sir.
Okay. Gene for gelatinous drop-like dystrophy is located on which chromosome?
Pass.
Guyton's test is used to assess?
Pass. Okay.
Okay. So logMAR value change for every optotype on ETDRS is 0.02. Patent's line was correct. Planet was done for aflibercept. Gene for gelatinous drop-like dystrophies on chromosome 1. And Guyton's test is done to assess the oblique muscles. I think they got one right, is it?
Yes, one right. Right, all response.
All parts.
So now the last team, team 4.
Team 4 has to go for the set 11. Yeah. Are you guys ready?
Yes, sir. Yes, sir.
Okay. Let's have the questions. The child presents with nystagmus face turn. On examination, the nystagmus is horizontal jerk and dampens on convergence. Pass. Drug of choice for NTG, normal tension glaucoma.
Pass.
Okay. World Glaucoma Day is celebrated on?
Pass.
Good. Anthony B bodies are found in which condition?
Pass.
Keaton protocol used for treatment of keratoconus. Come
What?
again.
Internuclear.
What?
First one.
First one.
No.
What they said? First one is?
I am no.
They were not sure. They were just
Okay. So
like-
it's pass only.
Okay, the diagnosis for first was infantile nystagmus syndrome. Drug of choice for NTG is any of the prostaglandin analogs. World Glaucoma Day is 12th March. Anthony B bodies are found in schwannomas, and Cretin protocol is used for keratoconus, PTK plus CXL. Okay.
So we are through with the rapid fire round also. So now the last set of MCQ is remaining. So I again welcome Dr. Sugata sir for the same.
Okay. So can we have the first question, please? So in X-linked retinoschisis, which is true? Option A, the splitting of the retina occurs at the level of inner plexiform layer. Option B, electrophysiology reveals negative ERG. Option C, the main cause of visual loss is recurrent RD. And option C is myopia is common in retinoschisis. Time starts now. Okay, so the answer is electrophysiology reveals negative ERG. Myopia is not that common. It's actually, we quite often get hypermetrophic reflex and is caused by the mutation of the RS1 gene. Retinoscopy, as I said, often shows hypermetropia, and the split occurs predominantly within the inner retinal layers. And ERG is negative, where the B wave is reduced and the A wave is preserved. And the main cause of loss of vision is macular degeneration or macular changes. So we'll move on to the next question. So Hulusi Behçet associated with Behçet's disease was the time option A is pathologist, option B is ophthalmologist, option C is dermatologist, and option D is optometrist. It's an easy question. Time starts now. So Hulusi Behçet was a dermatologist from Turkey, and he described the Behçet strand. Yeah, so answer is option C. Behçet strands of aphthous ulcer, genital ulcer, and ocular inflammation. So we move on to the next question. Which ocular manifestation is most typical for untreated primary central nervous system lymphoma, that is PSNSL? So option A, nodular conjunctival infiltration. Option B, nodular iris infiltration. Option C is endogenous candida endophthalmitis. And option D is nodular retinal infiltration. Time starts now. Okay, it was an easy one. So the answer is a nodular retinal infiltration. So primary intraocular lymphoma, which is a part of PCNSL, is basically involving retina, vitreous, and optic nerve head without concomitant CNS involvement. The orbital lymphoma or the other lymphomas which are metastasizing to the eye can be there in iris or orbit or lagrimal gland or conjunctiva. And the most common findings on ocular examination is actually vitritis. And for any iritis at the extremes of ages, we have to think of masquerade syndrome, and lymphoma is one of them. So we go on to the next question. So this is a tricky one. Name the movie. So option A is iris. Option B is cornea. Option C is retina. And option D is blood in the tear. Time starts now. So it was probably a difficult one, and the answer is retina. It was a movie which, can we have the next slide, which was actually directed by Carlos Ferrer. And it was a suspense movie where a woman actually was giving a trial of some sleeping pill and had a series of nightmares, and then she herself in a run and was trying to find out who was involved and was trying to uncover the truth. And it was a movie which was actually shot by only three crews, which is remarkable. And it was an 87-minute film called Retina. So we move on to the last question of this group. So identify this instrument. Probably an easy question. Is Erisefec option A? Option B is foreign body magnet. Option C is Mackay Mark tonometer. and option D is the cryo probe. So time starts now. Okay, so the answer is the Mackay Mark tonometer, which actually is one of the useful instrument in measuring intraocular pressure in edematous cornea. So with that, we come to the end of this MCQ round. I hand over to Shilpi. Hello, Dr. Shilpi, are you there?
Yes, sir. Sorry, I was
Yeah.
mute.
Yeah,
So thank you, sir. So team 7, this case-based question is remaining. So I request Dr. Divakant to please share the screen.
Yes, Dr. Shilpi, I'll just do that. Is the team ready?
Yes, sir.
Yeah, we'll just, so there was a clincher in the diagnosis in that case, so we are just changing that question for you. Okay. Okay. Yeah. Can you see the blank screen?
Yes, sir.
Okay. So let's start. So this is the case. And a 50-year-old male presented with no prior ocular history presents with a partial shadow in vision in the left eye for the past 24 hours. The OCT scan is shown here, and we'll start the question. Yeah. Describe the OCT, please.
So the spongiform thickening is seen and there is neurosensory retinal detach, like subfluid.
Most likely diagnosis.
Pass.
And how do you manage this case?
Pass.
Okay, so something to note in this is, sorry, just a second. I think basically this is a case of branched artery occlusion. We can see this hyperreflectivity that is there. This depicts an ischemic area in the retina. So that is how you define the OCT, the hyperreflectivity in the inner layers, inner layers, and then the diagnosis is branched retinal artery occlusion. These cases usually resolve on its own, but you have to get analysis by a cardiologist and rule out stroke in such patients. Okay.
So thank you, Dr. Divakant.
Yeah.
So with this, we end with today's quiz. So Sai, do we have the winners of the last episode with us? Meanwhile, we have Dr. Soumya. She is a mentor of Team Morning Glory. Dr. Soumya?
Yeah, hi, Dr. Shilpi.
Hi.
And hi, and it was a very nice quiz. Beautifully done, sir, and Dr. Divakant Mishra also. And really enjoyed the questions, which was so, really, initially it feels as though they are easy, but they are not. You need to really think about and then answer, I guess. It's beautifully done, and thanks for all the nice questions. Thank you, Dr. Shilpi.
Thank you, ma'am. Thank you. And Dr. Abhishek Das? He's a mentor of
Yeah. Hello, Dr. Shilpi. Yeah, it's nice to see you. Actually, I'm out of India, but still I'm participating to
Great,
support my teammates. Yeah, it was very nicely organized. Nice to see you all again. Thank you so much.
Thank you, sir. Thank you. Thank you. Sai?
Not yet, madam.
Okay. Okay. So thank you, Dr. Devakant. Thank you, Dr. Sugata, sir.
Yeah,
for-
Dr. Shilpi, you put in so much of effort in organizing so many rounds of quizzes throughout the year along with Dr. Prashant. So hats off to you both. And again, Dr. Sai, with the help of Sai, this is possible, we know that. So thank you very much for this lovely quiz and making me a part of the quiz as well.
Thank you, sir, for the last moment helping me out with the rapid fire round. And it is basically possible because of the quiz masters only. You frame the questions and everything. We are just collating it and just conducting the quiz. Thank you, Dr. Divakant.
Thank you so much, Dr. Shilpi, for making me part of this always. And as Sir said, it's such a big task. I mean, questions, I know that's a big part as well, but collating it, everything, and getting things done so smoothly. So hats off to your whole team and Prashant sir. Yeah.
Our team, we are all since beginning, actually, we are all together. So, yeah.
Right.
So thank you, teams. So we will be meeting again after 2 weeks, Wednesday, 8 p.m. on 5th of June for the finals. The result of the semi-final 1 and 2 we will declare within 3 to 4 days. So all the best to everyone. So now it's time to say bye. Thank you, everyone. Thank you, Sai. Thank you, Team Microvision.
Thank you, ma'am.
Okay. Bye.